Welcome, everybody. I'm Bonnie Maldonado, and I'm a professor of global health and infectious diseases in the Department of Pediatrics. And I'm also the division chief for infectious diseases here. And today, I think we have a special session for COVID-19 in children seminar. This is something we haven't done for some time. And I think it's exciting to be back and talk a little bit about all of the advances that have been made so far. So I wanted to go ahead and get started and give you some updates from around the country and a little bit around the world as well. There we go. All right, so we're going to do a little bit of a COVID-19 update today. And so let's go ahead and get started. I'm going to focus on a couple of, these are my disclosures. I've been working with Pfizer on the maternal RSV vaccine, as well as on the pediatric COVID vaccines, as well as the Data Safety Monitoring Board for a different vaccine trial, and the NIAID Data Safety Monitoring Board as well. So we're going to do a little bit of an epidemiology overview, since we haven't really talked about this in a while, of COVID-19 and pediatrics. And then we're going to spend some time talking about vaccine efficacy, effectiveness, and a little bit on adverse events. And then really ponder what's the future of COVID-19 with respect to vaccines, boosters. There's a lot of information flying around, and I don't have all the answers, but we'll at least try to sort out some of the issues today. So in some ways, it feels like we are now leaving the pandemic, and we can fling off our N95s and jump into the future with full confidence. And on the other hand, I think some of us feel like the COVID-19 and SARS-CoV-2 continue to mutate and exert a presence in our lives to infinity and beyond. So there's somewhere, I think we live somewhere in between these two extremes. I'm not going to talk about those details. I think all of us have different, as we've learned over the pandemic, all of us have our own risk perceptions. So let's talk about the facts for children. And then I think the issues around adults, I think we'll leave for another day. But certainly it's very true that SARS-CoV-2 and COVID-19 are not gone. So let's just talk a little bit about what at the federal level has been happening. There's been quite a bit that's happened since the last several updates. So if you look at what has been happened just from October of last year to the most recent ACIP meeting, which was chaired by our faculty member, Grace Lee, at the CDC, there have been a number of issues, including the epidemiology of COVID-19, including MISC and hospitalization, vaccine effectiveness updates, COVID-19 vaccine safety updates, updates to vaccines in children 6 months through 5 years of age, including Moderna boosters. And actually, I'm going to talk about the Pfizer booster because that data wasn't available in February. And then finally, considerations for transition to bivalent primary series. Now, there were other topics, as you see there, but I'm only going to try to focus on these because of time constraints. So let's talk about the epidemiology. So this report has been, to me, one of the most helpful reports that we've seen in the US around pediatrics. In fact, as I said before, the American Academy of Pediatrics is the only organization in the US that started tracking children with COVID-19 and SARS-CoV-2 infections back in 2020. So they've continued to put this report out. You can find it at aap.org. And the data are more limited now because reporting is not so robust. But you can see that according to their most recent report from last week, we've had over 15.5 million COVID-19 cases reported in children 18 and under, which again is probably a big underreporting, representing about 18% of all cases, with a rate of about 20,000 cases per 100,000 children. So about 20%, again, reflecting about 20% of kids. We also see on the right the graphic showing from the beginning of the pandemic, tracking of cases in children, and you see the big Delta and Omicron spikes. And you can see that these numbers are thankfully starting to drop off quite a bit, although we know that some of that reflects at-home testing and not reporting, but also fortunately reflects the fact that we're not seeing as many hospitalizations and deaths. Now, speaking of hospitalizations, if you look at the weekly population-based COVID-19 associated hospitalizations of all ages, you see at the top there, the broken blue line are people 75 and older, and they continue to make up the majority of hospitalizations, followed by 65 to 74-year-olds, 50 to 64-year-olds, 18 to 49-year-olds. And then you see the pediatric hospitalizations are quite low, which is good news for all of us, of course. And then if you focus in a little bit more on children here, you see that the numbers for kids demonstrate that children under 6 months of age have the highest risk for hospitalization, followed by 6-month-old to 2-year-olds. And you can see that blown up there from August to February of this year. Now, when you look at hospitalizations by pediatric age group by week, you can see again that the numbers were originally highest for the teens or preteens, so the 12 to 17-year-olds. And more recently, the numbers have really been more evenly divided. You might say that they're actually trending more towards the under 6-month-olds and the 6-month to 2-year-olds. And I think this is reflective of the vaccination rates, and we'll get to that in a bit. So the older kids have been vaccinated, more likely to be vaccinated than the younger children. Now, if you look at hospitalizations for COVID, not just with COVID, you see that over time, Omicron continues to be a major, it continues to be represented as a cause of hospitalization, not just an associated factor of a hospitalization for another reason. So that over time, you see that many children ages under 4, as well as adults over 50 are still admitted for COVID, and adolescents and younger adults tend to be admitted with COVID, but less likely for COVID. So you see that the very young and the very old are more likely to present in the hospital with symptoms of COVID. Now, if you look at medical conditions for non-pregnant adults and children and adolescents under 17 for the underlying reasons for COVID infection, you can see that 96% of hospitalized adults have at least one underlying medical condition, with the most common being chronic lung disease, followed by cardiovascular disease, diabetes, and then obesity, and as well as others. But for children, almost over half of children have no underlying medical conditions. And of those that do, asthma is the #1 condition, followed by prematurity, feeding tube dependence, history of febrile seizures, and then obesity. And then if you look at these underlying conditions by age group for children, you see that obesity, asthma continues to play a very big role in all age groups, except for the under 2, where prematurity is most important, but obesity as well is very important, as is feeding tube dependence. So we know that those are underlying factors that still predispose children to be hospitalized. And if you look at vaccination status by age group, transitioning over to how that will affect hospitalizations in a second, you see that the 5 to 11-year-olds, over almost 60% are still unvaccinated, whereas just about 50% are not vaccinated, 12 to 17. And the number of vaccinated individuals goes up over age groups, with, again, 5 to 11-year-olds being the least vaccinated. And that influences, we think, hospitalization rates, because you can see that in December of last year, compared to adults who received an updated bivalent booster, the monthly rates of hospitalization were 16 times higher among unvaccinated and almost 3 times higher in vaccinated adults who didn't have a booster. And so we're seeing the impact still of boosters on risk for hospitalization, especially among those high-risk groups that we talked about earlier. And then finally, I wanted to just weigh in and talk a little bit about the variants to show you that right now we still have Omicron circulating, although Omicron variants are really evolving reasonably rapidly. And you see at this point, XBB.1.5 has been most common, and you see the numbers of of cases of variant strains are relatively low compared to the early B11 days, but we are still seeing that XBB.1.5 is important. And there's data that suggests from India and other countries that XBB.1.16 may be starting to show up around the world, and can be actually associated with what some people could describe as pink eye. So we haven't seen that really in the US yet. I didn't see any cases. There may be some that are in the works, but that has been seen at least in India and some other countries around the world. And then finally, if you look at COVID deaths based on death certificate data, you see that we've had almost 1,500 deaths attributable directly to COVID-19 among people 18 and under. which represents still about 1.4% of all deaths in this age group. So really still an important cause of death, especially in the very young and in the 15 to 17-year-olds. Finally, in going through the last epi slides, I wanted to talk a little bit about this publication that came out from PedsNet, where Grace Lee was one of the authors looking at pediatric long COVID. It was a retrospective cohort study of electronic health records from 9 children's hospitals in the US, looking at what we call a test negative study design, where you had compared over 600,000 children who were tested for SARS-CoV-2 and and looking at whether those children were test positive, test negative, and then looking at long-term symptoms 28 to 179 days following testing. And these symptoms were compared among the negative and the positive tested groups, because some of these are common symptoms that could be a result of other infections. And they were grouped into syndromic or symptom categories, systemic or condition categories, and medication used. So when you look at the data, about 60% or about 60,000 or 9% of these over 600,000 children at these 9 hospitals tested positive by viral test, and about 90% tested negative. And when you compared the rates of disease from a month to 6 months out after testing, the most common features were loss of taste and smell, myocarditis, and cough and cold, use of cough and cold preparations. But these were common in both test negative and test positive children. However, the risk of any incident of any of these symptoms was higher by almost 4% in children who had been previously COVID positive compared to those who had been previously COVID negative. So we know that the risk of long COVID in children is not high, but it certainly demonstrates that there's a risk, especially in kids who had been in the intensive care and those with complex chronic conditions. So, and we know that acute illness severity, young age, and comorbid diseases will affect the risk of long COVID, and we'll see what happens over time as we track long COVID in children. So let's talk about vaccine effectiveness. Well, as you all, I'm going to remind you, because it feels like time is really drawn out over the last couple of years, but we see that the primary series for Moderna and Pfizer are listed here. And you see that Moderna has a 2-dose series given, the second dose given 4 to 8 weeks after the first dose, whereas the Pfizer vaccine for basically the same age group, 6 months to 4 years of age, consists of 3 doses given about 3 to 8 weeks apart for the second dose, and at least 8 weeks later for the third dose. These were approved. Moderna was approved in August of 2022, and Pfizer was approved in September for these primary series. And then in December, the FDA granted emergency use authorization for the Moderna bivalent booster for children 6 months to 5 years of age, and the use of Pfizer bivalent as a third primary series dose. So instead of giving the third dose as a monovalent, they were allowed to give the third dose as a bivalent. They weren't allowed to give a booster at that point. And then on December 9th, they updated bivalent booster use for children 6 months to 5 years of age. And then just if that weren't complicated enough, this is a paper that we published, with a number of people around the country looking at the pediatric Pfizer vaccine, showing data that of safety and immunogenicity and effectiveness of the Pfizer vaccine in children under 5 years of age. That was published in February. And then just a few weeks ago, the FDA authorized the Pfizer bivalent booster for children 6 months to 4 years of age. So the summary here is that all children 6 months and older are eligible for primary series and bivalent boosters by both Moderna and Pfizer vaccines. So they can all receive bivalent vaccines as primary and booster doses. Now, let's, after all of that, what has happened to uptake? Well, you can see here that if you look at COVID vaccination coverage as a percentage of the total age group, population by age group, you see that children, the overall summary here is that children have done very poorly, especially those under 5 years of age. So you see that 92.5% of kids under 2 have not been vaccinated at all. 89% of kids under 5 of 2 to 4 years of age have not been vaccinated, compared to children 5 to 11, of whom 60% have not been vaccinated, and 12 to 17 years of whom about 28% have not been vaccinated. So you see that while adults continue not to get boosted, with only 40% of people over 65 being boosted, children, especially those under 5, are still not vaccinated. And then you see here again, age-adjusted rates of hospitalization by vaccination status and age. You see for 5 to 11-year-olds, the unvaccinated kids continue to be the highest risk for hospitalization. And those who are vaccinated with no bivalent booster are the next likely to be at risk for all those age groups. So we see that boosters still are associated with better outcomes, or less risk of hospitalization. Now, what do we know about vaccine effectiveness? And I'm going to just briefly say that to remind you that for the monovalent, before we had the bivalent Omicron plus ancestral strain vaccines, for the Moderna vaccine, we see that the adjusted vaccine effectiveness was 40% for one monovalent dose, and between 36 and 60% for 2 doses. For Pfizer, 1 monovalent dose is associated with about 19% effectiveness, and 2 doses between 31 and 40% effectiveness. So much better effectiveness over time. And this is against symptomatic infection. There are other data regarding risk for hospitalization, but again, this is really just baseline symptomatic infection, whether it's serious or not. The limitations, of course, for this data for children is that vaccine coverage is very low. So vaccine estimates are not always great when you have smaller numbers. So the conclusions, of course, were that monovalent primary vaccinations really were protective against symptomatic infection in 3 to 5 year olds, and children should stay up to date with these vaccines. Now, if you look at the Pfizer vaccine, bivalent booster, you see that the adjusted vaccine effectiveness for 2 to 3, for bivalent boosters after monovalent primary series, sorry, it's complicated, is between 54 and 65%. And in 5 to 11-year-olds, and in 12 to 17-year-olds, it is between 53 and 68%. So really pretty good coverage there, pretty good effectiveness. And in adults, the numbers are actually lower. So you see that they range from 28 to 51%, depending on what combination of boosters people have gotten, as well as what the ages over 18 are. So we see that children continue to have better vaccine effectiveness after boosters, despite the fact that they're not being used very much in children. And then in adults, you see another slide here looking at the relative effectiveness of bivalent boosters against symptomatic infection in people over 18, again showing that the rates are lower, but still between 21 and 38% protective against symptoms. Now, we know that then in summary that bivalent boosters against symptomatic infection are effective, but there is early evidence that waning occurs over time. And we know that there are other data that I didn't show you here, that these boosters also are effective in reducing the risk of emergency department and urgent care encounters and hospitalizations in adults over 18. Those data weren't available for children because there are less children being hospitalized. So let's talk specifically about what's going on with considerations for boosters and primary series vaccination. So let's talk about background here. We know that there are bivalent boosters in the US, as we just talked about. They first became available in September 22. And as of February of this year, about 52 million doses have been administered in people ages 5 and older in the US. And remember that the booster was just approved recently for children under 5. And that includes about half of those doses in people 65 and older. And the data demonstrate safety as well as efficacy, effectiveness in reducing risk for hospitalization, urgent care, emergency department, and to a certain extent, symptomatic infections that don't require care as well. And you can see here an outline of the vaccine uptake by age group from August 2021, when these boosters were rolled out, to January of this past year. And you can see in this slide, it's a little complicated looking at primary series in general by age are in the solid lines, and booster doses by age are in the dashed lines. And you can see that uptake overall for primary series was high, but again, this is for people 12 and older. It doesn't include children 5 to 11. So you see that most of the uptake for primary series occurred between December 2020, of course, and really dropped off by June of 2021. And then booster authorizations occurred in August and September of 2021. And you see that the highest uptake really occurred in people over 65 and less over children 12 to 17, but still a reasonably decent uptake among 12 to 17-year-olds, but not robust. And you see that as time has gone on with the second booster authorization and then the bivalent booster, we've seen lower and lower uptake. So we are facing the risk of vaccine fatigue, even though the disease continues to circulate. Now, if you look at this slide here, and you see the number of COVID bivalent boosters among people 12 to 39 years of age by vaccine type, you see that Moderna and Pfizer have some differences in uptake over time, but again, they've both been dropping off at pretty much an equal rate over the last several months. Now, let's talk a little bit about incidence of verified myocarditis and or pericarditis after vaccination. And just to remind you that there were some issues around safety, and that was the safety signal for myocarditis after vaccination in 12, especially in 12 to 17-year-old males, with an incidence rate of about 146 cases per million doses of vaccine. So we know that that has continued to be true. These cases have been overwhelmingly short-lived, mild, have required hospitalization in many cases, but with resolution of symptoms in virtually almost all of the children who have received these primary series. Now, you also see when you look at the first monovalent booster dose and the bivalent booster dose, you see that especially for the bivalent booster dose, again, remember the numbers are smaller, but you see no cases of myocarditis in the 12 to 17-year-olds and one case in a male 18 to 29 years of age. And for the primary monovalent booster, you do see some cases there, especially in the 12 to 17-year-olds. So the numbers are smaller for the bivalent booster, but the risk still exists in the 12 to 17-year-old males in particular. And that, again, continues to be monitored. And so far, again, those result in a resolution of symptoms in most of the children. Sorry, I'm trying to move to the next slide. And then if you look here at, that was Pfizer. And you see here the same data for Moderna. You see that there were 19 cases of myocarditis in 18 to 29-year-old males, 7 cases after the 2-dose primary series, 7 cases after the monovalent booster dose, and no cases after the bivalent booster dose, with 8 cases in those males between 30 and 39 years of age, and then 1 case in males after the monovalent booster dose. Now, if you look at reports to VAERS, which is the Vaccine Adverse Events Reporting System, here, you see just overall by Pfizer and BioNTech, if you look at all adverse event reporting, you can see that the number of cases is after about 52 million doses administered in the US. You see that the median age of reports is 54 for Pfizer and 61 for Moderna of the reporter of the person who had the report of the adverse event, with about 8,800 reports in males and 14,000 reports in females. And 94% of these non-serious, 1,400 were serious. And race and ethnicity distribution were comparable to the monovalent COVID-19 compared to the bivalent. So these follow the same track as what we saw with the monovalent boosters. And if you look at the actual non-serious and serious reports, you see here the listing of the types of reports that were submitted to VAERS following vaccination. This is for Pfizer, and you see that for the non-serious reports where they were COVID-19 disease, fatigue, headache, fever, a SARS-CoV-2 positive test, pain, cough, chills, dizziness, and pain in extremities. And for the serious reports on the right, you see COVID-19, SARS-CoV-2 test positive, dyspnea, asthenia, a condition aggravated, an underlying condition aggravated, fever, 83 deaths, a cerebrovascular accident, cough, and fatigue. And these are, again, are always monitored to see if they are actually associated with administration or if they happen to be reported anytime after administration of the vaccine. And you see for Moderna, the reports are similar given the number of doses that were given, and you see the types of symptoms are very similar in both of these groups. And so when you think about considerations for bivalent primary series, we certainly have to take into account effectiveness. We have to take into account safety, of course, and especially we need to know what is the benefit of a bivalent primary series compared to what we did in 2020 through 2022. Do we continue to need primary series? And then we can talk about, do we continue to need boosters? So we know that children and adolescents can develop severe COVID-19. Nearly 1,500 children and adolescents have already died from this disease, and half of those who were hospitalized had no underlying medical conditions. During all periods, including now, COVID-19 hospitalizations and mortality are consistently higher among unvaccinated persons than among those who had a primary series, and among people who had a primary series compared to those who had an updated booster. And we know, of course, you've seen the data here, that many children remain unvaccinated for COVID-19. So the question we really have is, should we be giving, continuing to encourage primary series, and who should get these COVID-19 vaccines? Well, we know, and we saw that in winter months, they can impact COVID-19 epidemiology. Immune escape variants, of course, have impacted COVID-19 epidemiology, but we did not see, and we were happy not to see the same level of increases in cases and hospitalizations as previous winters. This probably a reflection of population immunity, although we do know that in other countries around the world, there were surges, especially in some of the Asian countries and South Asian and Indian country in India. We did see surges last year, again, among populations that had already established prior population immunity, in part possibly because of new variants, and again, may perhaps waning immunity. So the time since the last COVID-19 dose may both increase the incremental benefits of a vaccine and decrease the risk of myocarditis. We know there's some data from Canada, in particular from early in the pandemic, that the longer you waited after you gave the first dose of a vaccine, a primary series, the less likely you had a risk for myocarditis. We know that vaccine protection likely declines over time, and a plan for a fall booster dose could provide added protection at a time when many would be about a year out from the first dose. Remember, the boosters were approved, the bivalent boosters were approved in September of 2022. So future epidemiology and SARS-CoV-2 virus evolution will help us determine the continued need for fall boosters. And we already know that for older individuals and those with high-risk conditions, FDA is already considering an additional booster before the fall, but we have not seen that happen yet. So are there still populations who still need a primary series? Well, yes, the answer clearly is that unvaccinated young children, there's still evidence that we would like to keep them protected. Whether or not that's mandated or not is a separate issue, but it would be still important. And I think most bodies still recommend that children need to be vaccinated with a primary series. For most older children, adolescents, and adults, future doses would be a boost. Young children will continue to age into vaccine recommendations at 6 months and could be SARS-CoV-2 naive. And some populations of young children still need a prime and boost to optimize immunity. So in summary, children under 2 have higher COVID-19 hospitalization rates than older children. Children under 4 are less likely to have both prior infection and a prior vaccination. Children have frequent visits to healthcare providers. The ACIP discussed continued primary series recommendations for young children. It's continued to be recommended, as you see there on the right, by the American Academy of Pediatrics. And both ages were discussed, and the ACIP did not vote on or have a clear consensus. The AAP continues to recommend this, however. So when we look at monovalent, Moderna bivalent primary series, this is recent data that's not been published, just to go back over the data around the bivalent approval. There's an ongoing unpublished phase 3 open label study of children 6 months to 5 years in the US, and they use the original historical control primary series to compare the bivalent vaccine. And they enrolled almost 5,000 children in the original study and 179 children in the bivalent study, with median follow-up of about 102 days. For 102 days post-dose 1 for the original vaccine and 85 days post-dose 1 for the bivalent. What you find in the results is that the geometric mean neutralizing antibody titers against the bivalent is quite high. There you see neutralizing antibody geometric mean ratio of 25 compared to BA1 compared to the original strain. Now, unfortunately, there's no data here on Omicron, on the current Omicron strain, but this is still an Omicron variant. So we see that the safety in the study demonstrate these unpublished studies of 142 kids. The percentage of patients reporting local or systemic events was similar to or less than percentages seen after the original vaccine, which included pain, axillary or groin swelling or tenderness, and erythema, which were the most common events. Irritability, crying, sleepiness, and fatigue were the most common systemic events, with no grade 4 solicited adverse events reported. And there was one SAE, one serious adverse event of an asthma exacerbation. And you can see here a listing of the different systemic and syndromic responses, as I outlined in the previous slide. So you see that there was a high degree of local reactions for pain, mostly pain, some for erythema, swelling, and axillary tenderness, but numbers were pretty low for the others other than pain. And you see that fever occurred about 9 to 16% of the children, with higher rates of irritability, sleepiness, and loss of appetite. Now, the data for the Pfizer vaccine that we talked about was published last month in the New England Journal of Medicine. You see here on the right that of these children, there were, when you followed them after 7 days after the 3rd dose of the bivalent vaccine series as a primary series in 6-month-olds to 2-year-olds, you see that there were 13 cases of SARS-CoV-2 in the 6 month to 4-year-olds, compared to 21 cases in the placebo group for an efficacy of 73%. And then in the 2 to 4 year olds, the efficacy was 71%. And in the 6 month to 2 year olds, so the efficacy was about 76%. So high efficacy. In addition, of the almost 1,200 children that were enrolled in the study, who were 6 months to 2 years of age, and the 1,800 who were 2 to 4 years of age, the immunobridging was also well demonstrated. I didn't have the data here, but the geometric mean ratios of seroresponse were very good. And the reactogenicity events were mostly mild to moderate, no grade 4 events, and low incidences of fever reported between the vaccine and placebo recipients. So when we come back then to considerations for a bivalent primary series, there is concern. Some of the concerns that have been raised both at the FDA and the CDC is that the initial exposure to one virus strain may prime B cell memory and limit the development of memory B cells and neutralizing antibodies against the new strains. That is, any strain that came, say, after the BA1 that was measured in this vaccine trial versus other Omicron variants that are coming along the line, or other types of variants that may show up in the next year or so. And we know that prior infection and our vaccine history likely has an impact on subsequent immune response. We know that affinity maturation can occur, so the ability of memory B cells to mature over time can happen, especially when exposed to newer strains. We know that vaccines continue to be able to provide a broad boost to antibody responses, and imprinting concerns related to the incremental benefit of updated variant-specific vaccines continue to be voiced, but there hasn't been strong evidence of this imprinting issue. It continues to be studied, but has not been seen at this time in controlled trials. When you compare monovalent and bivalent vaccines, you see that there were several studies comparing antibody titers with recent Omicron sublineages. The ratio of antibody titers from the bivalent vaccine compared to the monovalent is shown here. And you see that for live virus neutralization assays, it seems to be a better measure of antibody responses, neutralizing antibody responses. And you seem to see that overall, most studies show improvement in neutralizing antibodies for subsequent Omicron sublineages with a bivalent vaccine. And that dark brown line there is a ratio of 1, which means no boost. And you see that for 3 of the studies, there is small to large increases in neutralizing antibody from the bivalent booster. And when we look at clinical data, we cannot directly compare clinical outcomes for monovalent and bivalent vaccines, but a study in the United Kingdom found that there was a 10% increase in relative vaccine effectiveness for COVID-19. And you can see here on the right, the number of cases with the Kaplan-Meier curve here was significantly lower for bivalent boosters compared to original vaccine boosters. So when we think about the overall benefits and harms of a bivalent primary series, they are able to induce an immune response when given either as a primary series or a booster dose. There are limited data that directly compare outcomes after receipt of a monovalent or bivalent, but there's indirect evidence that you can get an enhanced immunologic response, as well as potentially a reduction in an increase in vaccine effectiveness. These vaccines are all considered to still have a high degree of vaccine safety. And initial safety data are encouraging, but we are still in the process of studying some of these post-bivalent populations. So in summary, receiving a COVID-19 vaccine primary series continues to be important for prevention of COVID-19 severe disease, hospitalization, and death. Many children and adolescents remain unvaccinated. We need recommendations that are simple to implement. Currently, we have multiple different recommendations. I didn't show the slide, but there are a number of different products depending on how old you are and which product you use. Creating a bivalent primary series could simplify the whole administration process. Harmonizing a primary series and booster like we do for all the other primary immunization vaccines for children could simplify the presentation of the vaccine vials, reduce administration errors, and allow continued access to primary series. And so I will stop at this point. This is just a slide showing, with permission from one of my little participants in the pediatric COVID vaccine trials at our clinical treatment trials research unit. You see the study team there, and that was on blinding day last year. And she actually presented her vaccine experience at a third grade science fair, and she won first prize for that. So we were really, she was very excited to share that with the team and asked us to share it with everybody. So we also want to just mention, I'm not going to talk about these, we don't have time, but obviously the other impacts continue to evolve around understanding MIS-C, long-term symptoms or COVID or long COVID, loss of in-person education, even impacts that occur today, impacts on sports, socialization, mental health, death of caregivers and family members, and other downstream impacts of COVID-19, from which we would encourage individuals to continue to be as vaccinated and up to date as possible. So I'll stop there and thank you for your attention.
Thank you, Bonnie. That was extraordinary. This particular presentation was at the special request, I think, from our community pediatricians, and I want to make sure we have time to answer their questions. That was quite a tour de force, as always. I think we will make sure that the video is available on our YouTube channel for people who want to rewatch parts of it or share it with their colleagues. And then also, Bonnie, with your permission, we'll share some or all of the slides. And I loved the last slide. It was a great way to end. There are a few questions. Some of them came in early on, and I suspect might have gotten answered over as you showed more of the data towards the end, but just to make sure. First question is, why do children need to receive the monovalent vaccine before they receive the bivalent?
Yeah, unfortunately, that's a regulatory issue. So because the vaccines were, first of all, let me just say that we started enrolling children in these trials in, let me think now, gosh, June of 2020. So it took us a long time, and we're still finishing up some of the phase 3 primary series studies in the 6-month-olds to 2-year-olds, because we have to phase in the children with the 12 to 17-year-olds, then the 5 to 11-year-olds, and then the 2 to 4-year-olds, and then the 6-month-olds to 2-year-olds, et cetera. And so the point there is that when the data were available for the primary series, they were done using the monovalent vaccine. We didn't even have the bivalent yet. So we didn't have data or to receive approval for the bivalent vaccine for either Pfizer or Moderna until late 2022. And because of that, that's why they came in so late, that we've only been able to use booster data. We have to still go back now. We're doing the studies right now on the bivalent as a primary series. So even though we think it's going to work, you can't just assume it's going to work as well or be as safe. So that's really more of a regulatory issue.
Oh, great. Well, that was a great question. All right. From one of our lung transplant physicians, from Carol, do you have data on the T-cell subsets affected by the vaccine?
Yeah, there are a number of papers. I didn't have time to really go into the T-cell data. Unfortunately, the T-cell data has not been well integrated regarding effectiveness and efficacy. I think it's very clear that T-cells respond very well both to the monovalent and bivalent vaccines. And we also know that T-cell responses are much more long-lasting than B-cell responses. Unfortunately, what we don't know are two things. One is we don't really know whether the B-cell anamnestic response leads to improved effectiveness. That is, if you don't measure neutralizing antibody when you're doing your studies, does that mean that when somebody's exposed to the virus, that they're not going to get an immediate rise and boost of B-cell of antibodies, which could protect people? In addition, we don't know the interaction between T cells and B cells, or even T cells alone, in effectiveness data. So we don't have that data yet. There are snippets of data here and there, but nothing that brings it all together. However, we do think that T cells must play an important role in protection. We just don't understand the magnitude and the role.
Okay, here's a really great question. I think everybody will be eager to hear the answer. Do you think a time will come when COVID infection is treated the same as other viral infections? For example, children can still attend school and adults can still attend work even if they test positive.
Yeah, absolutely. I do think we need to treat this as, I mean, I'm hoping that we're heading into a time when this will become a background virus. Although background makes it sound trivial, it's not trivial. RSV, for example, is a quote unquote background virus, and it's not trivial either, but it would be not considered a pandemic shutdown type of virus. And yes, I do think we're heading in that direction. But one of the problems that I see with this virus, it has not yet established seasonality. So we don't really know how it's going to circulate over time. I mean, it's continued to circulate in low levels. It doesn't seem to have established itself as other coronaviruses do as a cold virus that has a seasonality to it. Now, if it doesn't do that, then I think it would really beg the question that we should, again, still continue to have people vaccinated, even if they've been infected before, because it does provide additional immunity, and hope that annual boosters, at least for now, will provide enough population immunity that we can keep circulation low. And I do think that individuals can attend school. I would still hesitate to send somebody to school if they're positive. I know there was a recent study that demonstrated that half of parents lied about their children being infected and sent them to school anyway. I'm not sure they're doing people any favors, because you still see that kids can get quite ill. And even if they don't get hospitalized, they get sick and they stay home. And that does have a toll on the child and the family. And we do know that there are impacts of long COVID as well, especially for kids who have underlying conditions. So I still wouldn't send somebody to school if they were positive. If they got infected, obviously, I think we're still at a point where they could go back to school pretty quickly. And I think there's evidence that we're able to get back to school without having to lock down schools if people just monitor their kids and keep them home when they're sick. By the way, many schools still, even before the pandemic, tried to keep kids home with symptomatic disease, no matter what it was. So kids had runny nose or fever, they couldn't go to school.
Yeah. Okay, so now there's a question, and it's related to California Department of Public Health sent out a communication today. So the question is, I may have missed this, but are we switching to a bivalent only administration soon for everyone? CDPH sent out communication today that no more ordering of monovalent vaccine will be authorized going forward, only bivalent.
Yeah, I mean, that just makes sense. I mean, we always update, whenever we have, for example, when we looked at Prevnar, we updated, the companies just stopped making the older version. Why wouldn't you want to update something with more valency if you can? There's no reason to use the old monovalent, because that strain, first of all, that strain is not around anymore. And the reason to keep it in there is probably as a backbone. At some point, the bivalent strains may change. The backbone may be the new BA1 strain, and then the new bivalent strain may be whatever's circulating at the end of the year. So we are going to see these vaccines, by the very nature of the way we give vaccines, evolve over time. And for example, the flu is a good example, is a good case in point, where we change the strains on a regular basis.
Okay. Also from the community, some parents still are not keen on the mRNA vaccines. Can you please update on Novavax for pediatric patients, and why no Corbevax in the US?
Yeah, that's a great question. And unfortunately, I didn't go back and look at my notes. Novavax has been somewhat popular outside of the US. The honest assessment of these vaccines is when you look at virtually all parameters, the DNA vaccines are just not working as well. And some of them have effects that are much more severe, not horribly severe, but they're more pronounced than the mRNA vaccines are. So yes, we understand. I think the issue around mRNA vaccines, and we know that some states are actually banning mRNA vaccines of any kind, which really, again, plays into this narrative that I believe is not based in science. But again, that's a whole other discussion. But we have not seen these vaccines come to the US, either because the companies withdrew them because of lack of interest here or lack of a market in the US, especially because they see how little uptake we're seeing in children. But the other reason is that if you look around, and there was just another study recently demonstrating that the DNA vaccines just aren't as effective overall as the mRNA vaccines. So there are many reasons. It would be nice to see a bigger palette of vaccine candidates available in the US and elsewhere. Certainly the World Health Organization is calling for more vaccine products for the world. So we just have not seen that happen here. So market forces are at play there primarily. It's not a regulatory issue.
Okay. And here's more of a personal question, somebody's own kids, about the best place to get a pediatric primary and booster series. Is the best bet to go to local pharmacies like Walgreens, or will it be available in a PCP office like a well-visit immunization?
You know, that's a really good question. I don't know the answer to that. I don't know how many, I haven't talked to the AAP recently about how many practitioners are using the vaccines in their office. I know that they're very complicated to give. There's a total of 11 different products you can carry because there's 6 Pfizer's and 5 Moderna products, because they vary based on your age. And whether you're getting a booster or a primary series. So there's 6 different vials you need for Pfizer and 5 for Moderna. And I don't know how many providers are using them. So that's a really great question. If somebody's online can answer that question, if they've actually gone to a local pharmacy with a child. I do know that a lot of my colleagues, when we're talking online around the country, just take their kids into a pharmacy, whatever that pharmacy might be. But I think one should check in with their primary provider first.
Yeah, we can check in with our medical director of PCHA and try to find out more about what the practice is right now.
That's a great idea.
Okay. And how about nasally administered vaccines for all ages? Are those on the horizon?
Yeah, people are looking at that. I think it's a great idea. We had talked about a nasal spray way back. The Israelis had an oral vaccine, which would have been really nice. That just kind of fell off. We don't know why. There are nasal spray vaccines that are being studied, and we all remember LAIV. I mean, we thought that was going to be a game changer because kids didn't like shots, and it just didn't do well. And then we had issues with vaccine effectiveness, and it just hasn't done well. So, but again, it would be nice to continue to see more vaccine candidates out there. So I don't have any updates. I know that they're being studied.
Okay, we have an audience member in Truckee. We are using them in our clinic here in Truckee. All Pfizer and Moderna are available.
That's great. There you go.
Good. That's great, and great community reach.
Thank you for saying that. I do think that there are people who are using them out there. I just think it's a matter of how much intestinal fortitude one has to keeping up with the different products. Again, that's the big conversation that I know that CDC in particular has been having around how well can we roll out the instructions. If you go to the instructions, they're not hard, but it's just really the matter of if you're going to use this on a regular basis, you just need to have your ducks in a row. The paperwork has to be ready. The vial colors need to be lined up. So, pediatricians of any specialty, I think, would know how to do this best. So I would imagine that it's probably much easier in pediatric practices to do than in adult practices.
Good. That was amazing. That was a great conversation. Right. I think we had all the questions. There was one question back at the beginning. I think it was.
Oh, and somebody says that in Menlo Park, they're using them all as well. So that's good news. Wonderful. Thank you.
Oh, fabulous. That's perfect. Okay. I think that's good. Thank you, Bonnie. You'll let us know if we can post your slides as well. I think.
Yeah, please. They're fine to use. They're
an incredible resource, and the video itself will be available on the YouTube channel through the department. So please share that with your colleagues. This was an incredible up to the minute, up to this morning update as always, Bonnie. Thank you.
Thanks a lot, everybody. Have a good day.
Thank you. Have a good day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.